our next panel is going to be exploring the impact of COVID-19 pandemic and what are lessons learned about colorectal cancer screening. And we'll start with a presentation by Dr. Iris Lansdorp-Vogelaar, who's the Associate Professor at the Department of Public Health of Erasmus Medical Center for Rotterdam in the Netherlands. And then we'll be following with a panel that brings us experts from Finland, from the UK, from the Basque region in Spain, and from Belgium. So we're continuing this process to bring you experience from different countries. But let me now hand over the floor to Dr. Iris Lansdorp-Vogelaar to give us some background on, how should we be integrating lessons from the last 2 years and sadly ongoing impact of COVID-19 on our health systems and our societies. Iris, the floor is yours.
So I'm hoping to provide you a little bit of insight of the lessons that we may have been able to learn from the impact of the COVID-19 pandemic on colorectal cancer screening. I want to start off with a slide that shows the impact of COVID on cancer in the Netherlands, just as an example of what we've actually been seeing all over the world. So here you see a timeline and you see the relative change in cancer diagnoses, starting here in around February when the first confirmed case of COVID was diagnosed in the Netherlands. But then exactly what you see here when we went into a nationwide lockdown is when the rates of cancer diagnosis really started to decrease. And this is just 2 examples of cancer, overall cancer and skin cancers, but we actually saw it over the board, and especially the screening cancers were impacted the most. And Stephen Halloran, who is actually also part of the participants here, did an informal survey among programs across the globe. And actually 23 out of the 28 programs that he surveyed indicated that they had suspended their colorectal cancer screening program because of the pandemic. And even the programs that hadn't done that, many of those also suffered from lower capacity and or participation with the program. This is an example from the Netherlands where you can see for 3 different years the number of invitations for FIT screening being sent out. In the blue line, you see the level of 2018, in the orange line, the level of 2019, and then in green, the level of 2020. And what you can clearly see from this graph is that halfway March, we stopped the program. So the number of invitations in March was about half of that normal. There were no invitations being sent in April and May. And then in June, the program was restarted again. But the good news was that in the end of the year, we were able actually to invite more people than we normally did for the program. So we're trying to clear that backlog of missed individuals that were due for screening already during that disruption period. And you can clearly see that from this graph over here as well, which is the backlog of invitations over time. So although there was already a little bit of a backlog in February, that is just normal noise, I would say, in the data. But then as the program was suspended, you see the backlog of invitations increasing over time. And although we restarted the program in June, we were not able to clear that backlog until after summer, when we actually had some additional capacity, and we cleared at least some of the backlog in those months following the summer. So that was good news. But the question was, what was the effect of these disruptions? How bad was it to have these disruptions, and how can we mitigate the impact? And that was why the COVID and Cancer Global Modeling Consortium was put together. It's a collaboration of several institutes on in the field of cancer, including the UICC, the International Agency for Research on Cancer, the Canadian Partnership Against Cancer, Cancer Council New South Wales, and the International Cancer Screening Network, on whose behalf I represent in this consortium. And the idea behind this consortium is that we're going to provide informed advice to governments as they rise to this health systems challenge that COVID has been facing. And the consortium consists of several working groups, but I'm going to focus now today on colorectal cancer screening, obviously. And so far we have evaluated 2 projects. And the first project that we did was simply to evaluate the impact of the disruptions to colorectal cancer screening during the COVID pandemic. And we wanted to look at how much it matters if you have suspension for shorter periods, so 3 months, all the way up to suspension periods of 12 months. And we also wanted to evaluate what the potential impact was of reductions to screening participation after that disruption. And then finally, we wanted to look at what catch-up screening would do for people who missed the screening due to the COVID-19 pandemic. And we did this using 4 microsimulation models, 2 from the Netherlands, ASCA, MISC and colon, Oncology from Canada, and the Policy 1 bowel model from Australia. So we try to have some diverse, by collaborating, some diverse outcomes for different countries across the world. This slide shows the results. It's quite busy, so I'm going to go through it slowly. In the left-hand panel, you see the additional colorectal cancer cases that would occur between 2020 and 2050 due to the disruption. And on the left-hand side, it's the additional colorectal cancer-related deaths in that same period. And each set of bars is the prediction of a different model. So all the way on the left, you see the MISC and colon model, which is the model that I work with, the predictions for the Netherlands. And you see that we have 3 colored bars: orange, which is a 3-month disruption to the program, blue, a 6-month disruption, and gray is a 12-month disruption. And as you see, the levels differ between the models. That also has to do with the different screening programs that are being offered in the countries. But they all clearly show that the longer the disruption, the bigger the impact on colorectal cancer mortality. Also, what it shows is that even with a 12-month disruption, if you look over a long-term period, the impact of additional cases and deaths is modest, 0.5% to 2%, depending on the model and depending on the outcome. But still, it is something that, if you look at how many people we're talking about, amounts to a large number of cases. Then in this second set of graphs, what we looked at is, if we take the 6-month disruption sort of as a base case, how much worse does it get if you have this 6-month disruption followed by a period in which there is 50% reduced participation because people are worried to go for screening because of the chances of being contaminated with COVID. So what if participation indeed is influenced by this disruption and by COVID-19? Well, you see from all 3 models, or all 4 models, I'm sorry, that the impact becomes much larger, and sometimes it almost doubles. So there can be a huge impact, and that is only for a period of 6 months. If we're seeing and experiencing waves like we do now, and these periods are actually extending to 2 years, these numbers and these additional number of deaths will be much larger. There's also some good news, because as you can see here, for most models, except for Policy 1 bowel, you only see 2 bars. Well, there actually is a third scenario, and that is a 6-month disruption scenario in which you're able to immediately catch up missed individuals after that 6-month period. So although these people have experienced a 6-month delay, if you offer them screening quickly after those 6 months, you see that the bars disappear, and which means that there's actually no excess colorectal cancer and no excess colorectal cancer deaths. So catch-up is a very good strategy to mitigate the impact. And that brings us to our second project, because yes, of course, it sounds ideal. Let's just catch everybody up. But we all know that we're facing quite some capacity constraints in our program. So what if we're not able to catch up everybody immediately? What is the best strategy to do that? And that's what we've tried to tackle in this second project. And here we are looking at different scenarios. So rather than catching up everybody in 6 months, how about if we do it in 12 or 24 months? And the alternative is, well, what if we do it at 6 months, but we increase the cutoff? And we see that we have different scenarios for the Netherlands and Canada and Australia, because we use different tests and we use different cutoffs to start with. But that is sort of what we're looking at. And we also looked at the combination of both. Again, we use the same 4 models to make predictions, but I'm only going to present the results of one model, and I chose my own, because otherwise it's becoming too complicated. So these are the results for the miscant model. And I'm sorry, I'm a modeler, so we love all of these complicated graphs, but hopefully if I go through it slowly, then it should be easy to understand. So in the left-hand panel, we see the change in monthly colonoscopy demand during that period after disruption. So what you see, if we take a 6-month recovery period and we stick to our original threshold, that is the top bar. If we do that, this original threshold, then we need 50% extra capacity because we're inviting everybody after the disruption period, and the disruption period was 3 months. So we need 50% extra colonoscopy capacity per month to screen everybody that was missed. But then we mitigate, and that's in the right-hand panel, 100% of the excess deaths. So we're able to completely avoid any excess deaths from the disruption, but we do require 50% extra colonoscopy capacity. So that's usually not something we can do. And what you can potentially do then, because we have a fit test, is increase the cutoff temporarily. And if you do that during that 6 months recovery period, so that 6 months after the disruption, you can, for example, halve your excess colonoscopy demand that you can see in this row, but this also sort of results in a 25% reduction of your mitigation. So you still can only prevent 75% of the excess deaths. While on the other hand, if we stick to our original fit threshold, so we have 47 micrograms per gram feces, but rather than trying to catch everybody up in 6 months, we say, okay, we'll delay everybody and we'll try eventually after 24 months, for example, to have everybody caught up. We only need about 10–15% additional colonoscopies per month during those 24 months. But we still almost mitigate 100% of the excess deaths from colorectal cancer due to the pandemic. So that's a better approach to take. So the take-home messages from this analysis are, if you want to mitigate the impact of the disruption to screening programs, it is important to keep the disruption as short as possible, catch up screening, and facilitate and promote participation to screening after disruption. And this can be especially important in light of disparities, for example. And if there is not sufficient capacity to immediately catch up, try catching up over an extended period of time, because this provides you the best alternative. So the good news is that indeed in the Netherlands, now that we have longer term data, we saw this huge decrease in colorectal cancer diagnosis during the first wave of the pandemic, but then especially in the screening age, because of the higher number of invitations, we do see that the rate of diagnosis is going up and that we're finding these people again now that we are inviting them to screening. And I want to acknowledge my colleagues from the consortium and thank you very much for your attention.
Thank you very much, Iris. And of course, your PowerPoint will be available for people to download from the DICE website, and as will this recording, so people will have a chance to digest. It's a very rich presentation, but I think it was very helpful for you to highlight both what would be needed in order to catch up, and then a reality check. You don't have 50% spare capacity to start doing more screenings and colonoscopies, so there needs to be other ways forward. And I noticed particularly how every single one of the models identified that when you have disruption, you're going to have more cases, you're going to have more deaths. The longer the disruption, the greater the impact. So that's the framework that we're going to use to put as the context for our next panel. And let me invite the next members of our panel. So that's Iris Seriese, the manager for the National Colorectal Cancer Screening Program for the Netherlands, Dr. Tytti Sarkeala, the director for screening for the Finnish Cancer Registry in Finland, Dr. Robert Logan, King's College Hospital NHS Foundation Trust in the UK, Dr. Maria Isabel Portillo Villares, the coordinator for the Colorectal Cancer Screening Program for the Basque region in Spain, and Professor Dr. Erik van Cutsem, the head of Digestive Oncology at Leuven University Hospital in Belgium, and a member of the board of Digestive Cancers Europe. So welcome to all the members of my panel, and we're going to have the same question to all of you, which is, what are the 3 key learnings from the COVID-19 pandemic in relation to colorectal screening? Let me invite Iris. Could you go first?
Yes, of course. Thank you very much. Yeah, it's hard to choose always, like what are the three key learnings. But in the Netherlands, we are lucky to have one of the best modeling team in the world. I can say with Iris by my side. So what we did is we decided to stop the program. As Iris also told, but that gave us time to rethink of how to postpone the program when we decided to start up again. And I think that was one of the biggest learning, to just include the program and start with first out, first in principle. So we just included everyone. We didn't make a selection on age, and we took a risk of knowing that people will be invited later than we would normally do or would normally hope. But we thought with modeling that was having the most or the best impact. So I think that was one of the key learnings. Also, we were very happy that the participation rate kept quite high or stayed quite high. So that was something which was obviously interesting for us to learn. And what did I say? What was the last? I think, it took us almost 1.5 years to get back on the backlog. But now, unfortunately, because the rise of the new infections, we see that colonoscopy capacity is also decreasing again. So, but what we learned is that we don't have to stop the whole program. I think in the beginning we did that, and it was also based on insecurity and solidarity for our healthcare sector, a really good decision. But now we try to not stop the program anymore, just go on in a slower pace. So that is something I will keep encouraging.
Thank you. So key message there is, where possible, don't stop it. If necessary, slow it down, but at least keep a rhythm going so you've got a mechanism.
Yeah.
Thank you. Let's get some messages from Finland now. Tytti, Sarkeala, what are your big lessons, 3 lessons that you've learned from trying to operate screening in a pandemic?
I remind you first that in Finland, we are actually piloting FIT screening currently since April 2019. So our situation is a bit different than, for example, in the Netherlands. And we have 9 to 12 municipalities who are voluntarily organizing screening, and the tests are taken at home, and then thereafter we organize colonoscopies in specialist care. And in Finland, the situation has been a little bit different compared to the Netherlands, since our invitations in spring 2020 were on pause only during 2 months in all these municipalities, and 2 extra months in one. And thereafter, we have sent invitations normally, and the delay in invitations in spring was compensated with extra invitations in autumn already. And it seems that the participation rate still has remained the same. It has been very high all around 80%, and it still is around 80% in 2021. And it seems also that the analytics of FIT samples have worked quite normally throughout 2020, and there has been only minor delays in colonoscopy appointments. So my conclusion is that people seem to trust the program in Finland and want to participate despite of any these pandemics, and also the healthcare decision makers and personnel in municipalities, they find screening important and want to continue it. But we have to keep in mind that this is a pilot, and only 9 to 12 municipalities have been participating to it. So we are starting a national program next spring. and we'll see what happens then. Maybe the situation is different then, but at the moment, our experiences are very encouraging that nothing special has really happened due to COVID pandemics in our FIT program.
Excellent, thank you very much. Let's bring in some experience from the UK now, and if I could invite Dr. Robert Logan from King's College Hospital in the UK to share some of your perspective. 3 lessons learned on trying to run screening in the midst of an ongoing pandemic.
So thank you very much, Tasmin. I'm speaking to you here from King's College Hospital, but I'm also speaking in my capacity as the National Clinical Advisor to the bowel cancer screening program in England. And what I was going to say was a couple of points. First of all, in terms of the experience of the pandemic, like everybody else, we had a period of 3 months where we stopped screening completely. But then as we started to come out of the first wave last year, we started to make some quite significant changes in terms of our whole approach to screening. And those were, firstly, a decision to stop BowelScope, which is our flexible sigmoidoscopy screening offer that we had started 7 or 8 years ago and were having problems in delivering because we didn't have the workforce. And we had been contemplating doing this for some time, but in the context of the pandemic, we felt that, to quote a wonderful phrase, we shouldn't waste a good crisis. And we made the decision quite pragmatically that there was no point in us trying to continue with our efforts to roll this out, and that therefore we should stop it. Politically, that of course requires you to offer something else instead. And so we then grasped with both hands the opportunity to start FIT screening from the age of 56 as a replacement to the flexible sigmoidoscopy offer. And that, of course, has all implications for the numbers of people you'll be putting through and what you'd be doing with the demand for colonoscopy. And so the third thing that we did, which I think is quite significant, is that we have also extended and rolled out the use of FIT, not in the screening program, but in the symptomatic service. And so now we are not quite mandating, but we are making a very firm recommendation that anybody with symptoms has to have a FIT test before they get to colonoscopy. And indeed, the threshold for that has actually been set at 10, but with a recommendation that between 10 and 100, patients are considered for alternative investigations such as CT colon or colon capsule endoscopy. And that way we are trying to skim off, both in the screening program where our threshold is at 120, the population at greatest risk of bowel cancer, and then something very similar for those in the symptomatic population. So those, I think, are the sort of 3 really big changes that we have instigated in terms of how we recover from this pandemic, and as we move forward to say, is this direction of travel we want to go in? Just one final point, if I may. I think one of the other very useful things that we had was, with the benefit of our IT system that is set up so that we can follow every single patient through the system. We know where they are, we know what stage they've got to, we know what their FIT test was. When we started to recover the service and restart, we took an active approach to only invite those people who had the very highest FIT scores and who had been waiting longest, to maximize our chances of finding cancer. And because we had all that information in our IT system, that was a relatively easy exercise for individual screening centers to undertake. And we shared all the information, then they were able to target that very precious colonoscopy resource that we had during the peaks of the pandemic to make sure that those people we were scoping were the ones that had the highest risk of cancer. And in fact, that's what we found. And when we now look back and we look at our information that we have, we are finding twice as many cancers now as we were 2 years ago. And that's a consequence of the better uptake of FIT compared to guaiac, and the fact that we've rolled it out across much more of the population.
Excellent, thank you very much. So it's not so much rationing, but it's a logical approach based on needs, and that this has delivered fruit in terms of identifying twice as many cancers as before. Let's now turn to Spain, and also a large European country where health is quite decentralized, so there may be different approaches in different regions. But from the Basque region, Maria Isabel, what can you share with us? What are the lessons to be learned?
First of all, thank you very much for the invitation. And this is difficult to answer this question because we are learning. Yes, we stopped completely the program in 2 months, and restart in May, at the end of May, and we will start the invitations on colonoscopies. All colonoscopies, if positive, are performing in 2 months, later. But the problem was the invitations. We extend the invitation, for more than 70% of the population target. We are recovering the invitation. We extend the invitation to 70s because our program is a population-based program from 50 to 69. And we are monitoring this extended program in this year, but we investigate what is the new interval cancer because of delay, because maybe it's not we are detecting some interval cancer because of delay, but fortunately this colorectal cancer are in states, early states. Other thing is our participation rate compared to 2019, 2018 decreases slightly, because we launched a campaign of information about participation for all population, and included patient associations and primary care health physicians and nurses and all the team. And that is very important because even if it was difficult to access to healthcare to drop up the sample, any health center with safety measures considered is very important to participate, and participation rate decrease, but it's over 70s, and decrease in all age group and in all in men and women, but it's very high. This and we consider that this is important to increase the participation rate in people less than 60s, because and people deprived, because maybe because of the pandemic, deprived people increase inequalities in participation. The other thing is we consider that because of the burden of colonoscopies, and it's difficult to, because of the safety measures, decrease the capacity of the colonoscopy offer. We consider a consensus protocol after post-polypectomy surveillance, and it's carried out in 2020 in October. And we are monitoring the decrease of the colonoscopies in some adenomas of high risk for 3 years instead of 1 year. And that is very, very important because this decreasing is about 20% of the colonoscopies. It's important to consider that for physicians, GPs, and endoscopists, all team, that is very important to prioritize the fit test, after positive test, even in symptomatic tests with 10 threshold.
Thank you very much for giving us some examples from the Basque region and how you managed to address some of the issues and engage more participants. Let me now bring in the last member of my panel, and that's Professor Dr. Erik van Cutsem. He's going to give us some experience from Belgium and beyond. Erik, floor is yours.
Much so. Thanks for the organization. And just as an introduction, I represent here DICE. On the other hand, also professor of GI oncology at the University of Leuven. And I was chairing the screening program for colorectal cancer screening in Flanders. You may know that in Belgium we have 2 regions. We have a screening program for screening and prevention, a screening program in Flanders, and a screening program in the French-speaking part that's called Wallonia. Just first, a couple of numbers. If you look in Belgium, we have every year between 60 and 70,000 new cancers. I'm speaking of all cancers, 8,000 colon cancers. And what we have seen is that in 2020, we saw a decrease in all cancer diagnoses of 6% compared to 2019. So that means that around 4,000 patients were not diagnosed with cancer for all cancers compared to the year before. If you look in the first period of 2021, then the backlog is a little bit decreasing. Now we have less than 4% in the first 4 months compared to the same period in 2019. If we go to colorectal cancer, then we see that in 2020, we had 11% less colon cancers diagnosed compared to 2019. If you look in the beginning of 2021 compared to the beginning of 2019, we have 10% less. So the backlog is coming, we're decreasing the backlog. The question is this all due to the screening, lower screening? It's not clear. If you look at, I mentioned to you that we have a screening program in Flanders and in the French-speaking part. They were both put on hold. In Flanders, it was put on hold in the first wave for 2 months, and in November in the second wave for 2 weeks. If you look at last week, the numbers of participation and so on were disclosed of 2020 compared to 29. Then we see that participation to the immunological FOBT, so the FIT, was 48% in 2020. It was 51.5% in 2019 and 2080. So there was a slight decrease in the participation in the Flemish part. We don't have yet the numbers of the French-speaking part. If you look at the total coverage for screening in Flanders, where the screening program works, with coverages around 65% and participation above 50% before COVID. In Wallonia, they have only a participation of between 10 and 20%, so much lower, so it's not working. But if you look at the coverage in Flanders, then we see that the total population coverage in 2019 was 64.6%, and in 2020 was 63.5%. So a small decrease in the coverage with screening, because as Villares said also in the modeling, we sent out after the closure of the program a bit more invitations, and some of the backlog was kept. So in general, what is the message? Difficult to give a clear message. In Flanders, it's a bit easier because we have better numbers, better registration in this setting. What is clear is for the whole country that we see a decrease in new diagnosis of colon cancer. Small part is probably a little bit due to the fact that we have a little bit lower participation and a little bit lower coverage, but that cannot explain the whole decrease in the number of new diagnoses. So that's one message. Two, it's not clear what's going to be the impact on the outcome and the survival. I don't think if there is such a short, let's say, putting on hold, that this will have at long term for colon cancer a big impact on the survival. We have numbers now that those patients who are diagnosed with colon cancer screening, that's also in the report, that have a diagnosis of colon cancer through the FIT program, that less than 5% are stage 4, while in the population, the non-screened population, it's more than 20%. But if we have these small differences, probably it will not have a major impact on the outcome, long-term outcome. It may have a small impact, but not a major impact in this setting. And the third and final message is what I mentioned already: the total coverage in a COVID year, 2020, for the population. The target population in Flanders was 63%. In 2019, it was almost 65%. So a small decrease, but not a major decrease.
We've got, I think one question coming into the chat, and that's a question to Iris. Do you have an understanding of what catch-up approaches being followed internationally? We've heard experience from the UK, from Finland, from Belgium, but does the cancer community talk generally? Do we have an understanding of how countries are catching up?
I only have anecdotal sort of experience. So I know that most people have just started again, and most, at least the countries that I know of, they invite the ones that were overdue and then try to get back to the normal schedule by increasing colonoscopy capacity. If I'm not mistaken, maybe Carlo can comment on that after this, but Italy might have taken a different approach, trying to prioritize based on prior test result. So people that already had some blood in their stool, but not enough for colonoscopy, prioritize those over people that had zero blood in their stool. The other thing that I know is that the International Cancer Screening Network, and Carlo can comment on that as well, is doing a survey they already did one after the first wave, but they're now doing a second survey asking how countries across the world have actually dealt with the wave, whether they restarted, when they restarted, and what catch-up they're doing. So hopefully by the beginning of next year, we will have more information about that.
Thank you. Let me ask the panel, because we've got just 5 minutes left in this panel, so I need a brief answer. What needs to happen at European level to support national efforts to catch up and maintain continuity of colorectal cancer screening? So, and let me start with Iris Seriese, and we'll go in the order that we went. What's one thing that Europe could do, because remember, Digestive Cancers Europe works at European level, that would help?
I was afraid that you will start with me, because I think that's a very, very difficult question, because for me, I don't have a clear idea of some countries why they don't even have a program in the first place, or why they are struggling to start up, or why they decide to do it one way when another way might be better in my eyes. So, but what I do think, which can help, is maybe from your organization or another European organization to have more insights on what the barriers are. So that would be maybe a start. Yeah, and I think these kind of meetings where we're all collaborating and sharing information will always help. So yeah, and I'm open to always tell other countries how we do it and what our concerns are. We're obviously also, everybody's trying, like Isabel also said, like we're learning day by day. But yeah, maybe start with investigating the barriers first, and then share information on best strategies.
Excellent, thank you, Iris. Tytti, could you share from Finland what one thing we could do at European level that would help?
Well, I think also that this kind of both national and international collaboration is very important. At national level, to get financial and legislative support for the program, and to kind of construct the protocol, both national and international collaboration, so that that the healthcare personnel in your country, they are ready to continue, and you collaborate with them to make the protocol. But also we have received a lot of information, for example, from Iris about the protocol in the Netherlands, and also from Stephen about the tests, and from Carlo, Italy, from their protocols and ideas, and that has been a very important issue for us.
Thank you very much. So it's incredibly valuable, this experience sharing and information sharing. Robert, from the UK, obviously it's a bit of a delicate subject, what Europe can do to help for the UK, but where do you see added value?
Listen, we have to continue to collaborate and work closely together. We are Europeans first and foremost, and I don't worry about the politics. So let's put that to one side. Obviously, both Iris and Tytti have made very sensible recommendations. My comment would be I think if we learn anything from the pandemic, it is recognizing that this is actually not a pandemic. It's a syndemic. The people who die, the people who don't take up the vaccines, they represent the same, demographic profile of the people who don't participate in screening. And what we have seen as we've moved from guaiac testing to fit testing is, just as Stephen predicted in the pilot study, is the reason we're detecting more cancers is we've got more uptake in those deprived groups who otherwise would not have participated. So to my mind, it is about ensuring that we have as broad a participation as possible. And that requires organized screening programs delivered from the center to regions, that it's not a haphazard insurance-based approach. It's one that is comprehensive across systems and as inclusive as possible, recognizing that a lot of those patients at greatest risk of bowel cancer are the ones that are unlikely to participate.
Thank you very much. Maria Isabel, what would you like to share?
Yeah, I agree with the previous participants. Yeah, because it's very important to invest in colorectal cancer screening, and invest in communication, and also invest in decreasing barriers to participate. Is very, very important. Yeah, it's time to share experiences, to share different strategies to increase coverage and participation. And participation and coverage in also in people with deprived or vulnerable situation. Yeah. Another hand, is possible to consider that the colonoscopies are the burden for coverage and for participation, because it's difficult to invite people if the colonoscopy are the capacity of colonoscopies is not high, and it's important to reach a consensus in prioritization of colonoscopies between all people, even patients. Yeah, because normally patients consider some patients consider it's better colonoscopy than FIT, or it's better, yeah, and that is a problem, yeah, because FIT plus colonoscopy, FIT test plus positive, decrease their mortality and decrease the incidence, but surveillance and other colonoscopies out of the protocols are maybe only 5% of decreasing. And it is important to launch a campaign for population and for staff about this subject. Thank you.
Thank you, Maria Isabel. And Professor Dr. Erik, can I invite you to share your last perspectives?
Yeah, I think it's important that we reflect in Europe, because it's not a national, not a regional problem, that we learn from each other in work groups like this. Of course, Europe does not implement the screening in different regions. It's even not in some countries a country, it's the region often who does this. But I do think that as well DICE, as other organizations, and Europe and the European Commission can play a crucial role in giving recommendations, sharing experiences, sharing the modeling and the numbers, like some of the numbers that we have shown here in this setting. So information, awareness, that's another topic that Europe can do and should do, is and that the different organizations, European organizations, can and should do, is giving awareness that we keep on doing this in order to avoid that the graphs are not becoming dramatic. I don't believe they're dramatic if we hear everything, but there is an impact, but that we have bring together the learnings, and that Europe and DICE and other organizations, all European organizations, give awareness.
Excellent. Thank you very much. And can I say on behalf of the audience, a very warm thank you to our panel, to Iris and Tytti and Robert, to Maria Isabel and Erik van Cutsem.